Right, welcome to those of you joining. We'll just give people a couple of minutes to get settled in, so just bear with us. We'll probably start a couple of minutes after 7, so just be patient. We're aware of some streaming issues, Wi-Fi issues, I think at my end, so apologies if you can't hear me. If you're struggling, raise your hand and I can repeat bits and pieces, but if you just bear with us for a couple of minutes. I can see someone's raised their hand. Oh, it's gone back on then. So just bear with us and wait. We'll start in about 1 minute when we've given people a little bit of time just to get settled and get things going. So bear with us. This is just for anyone who hasn't joined before. This is the last of 6 that we had planned, 6 glaucoma support groups that we've had planned. We are hoping to do more. We are sort of in the process of planning more that will be run in September and October. So do please give us your suggestions for future topics. We've had lots and we have a few planned. But if you can think of any particular topics that you really want, do make sure you suggest them, and we'll listen and plan any that we can, as many as we can. Equally, if you know of good speakers, doesn't have to be doctors. We've used consultant ophthalmologists up till now, but if you know of maybe someone from a local sight loss charity who's really good, or if your ECLO's great, or the nurse, and you think they might be interested in talking at future support groups, if they kind of host your normal support group, then do let us know. So yeah, give us lots of ideas for future sessions, because it's the last of our sort of pilot scheme and we'll be doing a few more. Right, I think we've sort of given people a minute or two now. So I'm just going to talk through a little bit of functionality in Zoom first. So welcome, this is our 6th glaucoma support group. It's about My Glaucoma is Getting Worse, What Might Happen. We've got Mr. Pankaj Agarwal from Royal Princess Alexandra Eye Pavilion in Edinburgh, who's going to be talking. If you have questions, you can ask them. The best place to ask them is in the Q&A. So if you wiggle your mouse or touch your screen, if you're on a tablet, there should be an option, some different options at the bottom. One of them says Q&A. Type your questions in there. Even if you don't have a question, have a look in there, because if you like a question, you can upvote it. You can give it the thumbs up, and then Pankaj and I will see that up at the top, and we can see which questions are the most popular for everyone who's attending. And you can ask your questions absolutely whenever you want. We can, if you have questions you want to ask, you can ask them now, or if you have questions at any point in the talk, you can post them in the Q&A and we'll be keeping an eye on it. There will also be a poll, so I'm going to launch a poll now, which is just a kind of how much do you know, and then we'll ask you the same questions at the end to sort of hopefully you'll have learned something. So I'm going to launch that now, and I'll keep that open for probably about 10 minutes, so you can answer those questions whenever you're ready. If you are watching this on Facebook, we're streaming this on Facebook Live. You can ask your questions there, you can post comments on Facebook, and they'll be copied into this webinar. So if you're watching on Facebook, you can still participate in the Q&A. Do post your questions. We want loads of questions, please, the more the merrier, so we can have a really lively group. So I'm just going to talk very briefly about Glaucoma UK. Bear with me while I get the screen up. Sorry. So my name is Joanna Bradley, and my role is Head of Support Services at Glaucoma UK, which was known until very recently as the International Glaucoma Association. So we provide support and information for people with glaucoma, basically. So we do 3 kind of streams of activity. We campaign to raise awareness of glaucoma and encourage people to get their eyes tested. We fund research into glaucoma, just sort of several hundreds of thousands of pounds a year, so it's not a huge amount. And we provide information, advice and support to people with glaucoma. So we have a helpline and support groups like this and a forum. So that's the kind of three main streams of activity that we do. We've got a brand new website to go with our brand new name. So it's called glaucoma.uk. If you go to that, check it out. We've got lots of information there. So without further ado, I am going to hand over to Mr. Pankaj Agarwal, who is, as I said, consultant ophthalmologist at Princess Alexandra Eye Pavilion in Edinburgh. He's going to be talking about my glaucoma is getting worse, what might happen. So over to you, Pankaj. Thank you.
Thanks very much, Jo. Good evening, everyone, and welcome. So the topic I have been given is to talk about my glaucoma is getting worse, what might happen. Now, this is not something this is not a common question which often patient asks to me, that my glaucoma is getting worse, what might happen. The common thing is the other way around. I tell my patient that your glaucoma is getting worse and you might need something or the other done. Now that's a good news in a way, which suggests that most of the patient with glaucoma, they don't realize that or they don't reach the stage where they realize that the vision is getting worse. Because when a patient tells me that my glaucoma is getting worse, generally it means that they have reached quite late or advanced disease. So fortunately, this is not a very common question. As I said, the common thing I ask patient and tell them that's looking at your results, your glaucoma is getting worse and what need to be done, then we discuss. So let's talk about the glaucoma, and how I see this is as a journey of a glaucoma patient. It starts with a diagnosis, which might happen, and usually it is the optician, the community optician, who suspect that someone is having glaucoma, refer to the hospital. Then hospital, you get a confirmation or exclusion of the diagnosis. Once you are diagnosed with the glaucoma, you are then told what type of glaucoma you have, and it's very important, if you don't know, that to ask what type of glaucoma you have, because the treatment depends on what type of glaucoma. Then the next step is the treatment. You have started on drops generally, and then later on discussed about other management options, what else need to be done. One of the important pathway, or one of the important thing in this journey, is information. Very, very important, because as you all know, glaucoma is an asymptomatic condition. So generally, it doesn't give any symptom initially. Yeah, it is not painful. You may not realize you have any problem. So information is very important for not only for the initial diagnosis, but for the long-term management monitoring of glaucoma. Then we will talk about support services. Unfortunately, some people will lose eyesight because of glaucoma, and we'll discuss about how to cope with the sight loss. And the last of it, which again, it can be very, very important, is registration. And we'll talk about a bit more about the registration thing. Okay, so what's the final destination for this journey? The final destination for this journey is to prevent sight impairment, is to prevent blindness till we survive. That's what every ophthalmologist is trying to achieve, that my patient shouldn't go blind till they live. That's what my aim when I treat patient. And that's where we want to reach. We all want to reach where we don't go blind. So before we talk more about glaucoma, it's important to just have a brief idea of what happens in glaucoma. So this is a picture of an eye. And if you imagine like an eyeball, and the pressure inside the eye is maintained by an aqueous or fluid in the eye. If the pressure increases for one or other reason, because of the blockage of the drainage channel, this increased pressure can cause pressure on the optic nerve, or what we call as a nerve of sight. And the pressure on the optic nerve will damage the optic nerve functionally. And that's a picture of the optic nerve when the doctor is looking at the back of the eye. That's what we are looking at the back of the eye. And you can see here, the the white of the eye, yeah, this is the healthy white of the eye, the healthy optic nerve. But the white of the eye, when it increases, this is what we call as a neuroretinal rim at the top and the bottom end, and that gets thin, and that what how the optic disc look on the right hand side of the picture. That's a picture of a person with glaucoma. Now, how this is manifested for a person with glaucoma is, this is a visual field. So if you look at this cricket match, a person with a normal vision on the picture will get everything very clear, not missing anyone. But if you look at the bottom picture, a person with a mild or early glaucoma may miss some of the players. As you can see on the left hand side of the picture, there are missing players. The batsman is missing in the lower picture. So this is how manifested in an early or mild glaucoma. But when the glaucoma get advanced, and this is again the picture comparing advanced glaucoma with a normal visual field, the upper visual field is normal. And if you compare this with a person with an advanced glaucoma, you can see a lot is missing in the picture. That's how it manifested in someone with glaucoma. Okay, so the next important thing is, what are the types of glaucoma? Now, glaucoma can be classified in number of ways, but for all practical purpose, for management purpose, we can broadly classify this into 5 broad groups. The commonest one all over the world is a primary open angle glaucoma. And if you see a picture on the right hand side, right in front, there is something called the drainage angle. So if this drainage angle is open, which is generally in people who are short-sighted, the angles are open, or we call it myopic, that generally they call the angle open angle glaucoma. But for some reason, if the angle is closed, which generally happens in people who are long-sighted or hypermetropic or plus power, so they get angle closure glaucoma. The next one is normal tension glaucoma. For all practical purpose, when we define glaucoma, we say, okay, high pressure, but actually high pressure. Many people, in fact, 1/3 of patients in my clinic have got a normal tension glaucoma. So their intraocular pressure is normal, which is between 12 and 21, but they still have glaucoma. Why someone will get a normal tension glaucoma? They may be at risk of normal tension glaucoma because of migraine, because of what we get cold hands and feet. So some problem with the vascular problem and all, and they tend to get normal tension glaucoma. The next classification is secondary glaucoma. Secondary glaucoma generally happens in younger people who, let's say, got inflammation or injury to the eyes, and they tend to develop secondary glaucoma. They are generally high pressure glaucoma and a more complicated glaucoma. And the last is congenital glaucoma. Even a child can be born with a glaucoma if they got a family history of an early onset glaucoma or a childhood glaucoma. That's a congenital glaucoma, and the management can be different. So it's important to know what type of glaucoma a person has. Now, treatment options. So very important to know, there is no cure for glaucoma. Not uncommon when we prescribe drops in the first visit to someone who have just been diagnosed with glaucoma. And there can be a confusion that, okay, just like an antibiotic course, this may be for 4 weeks. I've used the drop for 4 weeks and that's my glaucoma cure. No, sorry, there's no cure for glaucoma. There's no cure. The treatment is mainly aimed at delay or slow the damage. But we are fortunate, there are now many treatments. There are good drops which successfully we can achieve the target, which is to delay or slow the damage. All the treatments, nearly all the treatment we do for glaucoma, whatever type of treatment we do, is the main aim is to reduce the intraocular pressure. That's one number which we are trying to reduce. And if we can achieve what we called as a target intraocular pressure, which is individual, which is very much dependent on individual, if we can achieve that pressure, hopefully we will be able to control glaucoma and prevent further visual field damage. The first line of treatment generally is eye drops, which are, as mentioned, very successful. And there are loads of eye drops. We'll talk a bit more about eye drops. I believe you recently had a webinar organized by Glaucoma UK, where this were discussed in detail about all the eye drops and all. The next option is laser, which sometimes can be done as a primary treatment, and we'll talk about the laser. And generally, the last one is surgery, and we'll talk about what are the surgical options for glaucoma. But as I mentioned earlier, it depends partly on the type of glaucoma. So eye drops, what the eye drops do, they lower intraocular pressure. There are few eye drops and they work in different ways to decrease the intraocular pressure. Now, they need to be used lifelong, just like a blood pressure medication. Yeah, they need to be used lifelong. And I emphasize this to everyone when I start the drops. The only reason you may not need the drops in future, if you had some surgery to control intraocular pressure, and then you might be able to stop the drops. But generally, if that's not the case, you will probably need, if you got diagnosed with glaucoma, drops for the rest of your life. In some rare cases, when someone is diagnosed glaucoma, early glaucoma at a very late stage, they may not need drops at all. There are different types of eye drops, and I believe this has all been discussed. So I'm not going to repeat that again. Generally, we start with one eye drops, but very often you might need a combination of eye drops, maybe 2 or 3 eye drops to get the desired intraocular pressure. Any treatment in medicine have got side effects, and that eye drops also have some side effects. And it's important to know what are the possible side effects so that you can watch for it and let your doctor know so that the drops can be changed or some alternative treatment options can be discussed. Generally, I think most of us start with generic eye drops, and I don't see any problem with most of those. There are issues, but generally they are okay. Some people may not tolerate preservatives in eye drop, and there are now loads of options for preservative-free eye drops. In some cases, we prescribe oral tablets called Diamox or acetazolamide, and they are a temporary option to control intraocular pressure when you are planning for surgery or anything like that. Is there a place for lasers in the treatment of glaucoma? Sometime when I start discussing lasers with the patient, this is the common question. Okay, I never knew that we can do lasers. Yes, we can do lasers. And in glaucoma, there are 3 types of lasers which can be done. The first one is called YAG laser peripheral iridotomy. The second one, selective laser trabeculoplasty, complicated names, you don't have to remember. And the third one is a transscleral cyclodiode. So I will talk about the individual laser just in a brief. So if you looking an eye from the front, and you can see a hole done in the iris, so this is the whole YAG laser iridotomy. So making a hole in the iris to open up the drainage angle, and this is done in angle closure glaucoma. So this prevents a person from not only from an acute angle closure where the pressure can suddenly go very high, but also from a chronic angle closure glaucoma. So this is done for an angle closure glaucoma, or someone have got a risk of angle closure. The next one for open angle glaucoma is called laser trabeculoplasty, and you can see some laser shots being done in the drainage channel here. And this improves the outflow of the aqueous from the eye and thus help reduce the intraocular pressure. I also mentioned about the cyclodiode laser. Cyclodiode laser basically act on the structure which produces fluid in the eye. So it basically turns the tap a bit slow, and that's how it reduces the intraocular pressure. Most of these lasers are quite quick procedure. They don't take long, and pretty quick procedures and painless procedures. So let's talk a bit more about the SLT, or selective laser trabeculoplasty, which has been much in the news recently because now this can be used as a primary treatment. So someone who may tolerate drops or someone may opt for it. You can opt for SLT as a first line treatment. The beauty of SLT is that you don't have to remember using drops every day. You can avoid the side effects of the drops. So this is a very well known and a first line treatment. How this works? It works on the drainage channel to improve the outflow of the fluid from the eye and thus helps reduce the pressure. As I said, people who are allergic to the drops or who get side effects from the drops may opt for a selective laser trabeculoplasty. It's pretty painless procedure, takes 2-3 minutes to do in one eye. The success rate on average is 60 to 70%, and it's very smart and sensible procedure. But not everyone respond to this. So again, all the treatment is very much individualized. Some people will be okay with this, some people may not be. Now we move on to glaucoma surgery. So why someone will be offered glaucoma surgery? The bottom line is, if your intraocular pressures are not controlled despite the maximum tolerated therapy, or there is a documented progression in your visual field despite medical therapy, that where you will be offered surgery. Yeah. The surgery, again, if you look at percentage wise, very few percentage of people will be offered surgery. Most of the people are okay with drops. The other reason for surgery, if you're not able to use drops for some or other reasons, people who tend to forget things, people who got a very active life and may not remember to put the drops in, could be an option. But again, that need to be discussed with your own ophthalmologist or doctor. And the last group of patients who just cannot tolerate eye drops, people who got arthritis or severe dry eyes, they may not tolerate topical medication. And again, a surgery is a very good option for them to help control the intraocular pressure. Maybe I would say 20 years ago, there were only one or two surgery for glaucoma, and the choices were very, very limited, similar to the drops. But nowadays, there are loads of surgical options. One of the common thing which you might have heard is called trabeculectomy. The word augmented means we use anti-fibrotic agent with the trabeculectomy called mitomycin C to prevent the scarring, and that's what is augmented trabeculectomy. The next one is the tube surgery, which is mainly done for secondary glaucoma or glaucoma secondary to trauma or inflammation or uveitis. Those patients generally need tube surgery, or patient who had previous trabeculectomy but their operation failed, then they might have a better result with the tube surgery. One of the other surgery, which is slightly less invasive, is non-penetrating or deep spherectomy. One of the things which is the recent development, and again, you will, if you're not heard already, you will hear about this, is called MIGS. So MIGS stand for minimally invasive glaucoma surgery. So this, if you compare this with the trabeculectomy need a bit more cutting involved, a slightly longer procedure. MIGS are a shorter procedure with less invasive procedure. And I must say, cataract surgery, you might wonder what's the cataract surgery doing as an option for glaucoma surgery. Now, is a very, very important. It's very well known that cataract surgery helps reduce the intraocular pressure, not only in angle closure glaucoma, but even in open angle glaucoma. So sometime your doctor may offer you cataract surgery to help reduce the pressure. And I often get a question from my patient, okay, doctor, why cataract surgery? How can it help in reducing the pressure? It does. Definitely in angle closure, but even in open angle glaucoma, is an excellent thing. It might help reduce the intraocular pressure. So if we talk a bit more about trabeculectomy, it's a gold standard still, although there are lots of options, but it's still the highest success rate, and it still is with the trabeculectomy. Surgery, again, the goal is only to help and control intraocular pressure. It will not cure it. The surgery may last forever, but it may fail after a few years. So again, we need to just help control the intraocular pressure. It will not improve your vision of your glaucoma. And once we can get the desired intraocular pressure, that will slow down visual field loss from glaucoma. And that had been shown very clearly for trabeculectomy. So this is again a picture showing what the trabeculectomy does. Is basically we make a tiny hole in the eye, the fluid from the aqueous or from the anterior chamber, it drains on the superior part of the eye, and that is covered by the conjunctiva. And so there is basically a tiny cyst on the top of the eye, which is not visible, which is under the eyelid, and where the fluid drains and thus helps control the intraocular pressure. The success rate, as you can see, depends on individual unit, individual surgeon, but on an average, I can say 4 out of 5 patients, if not more, will have a successful trabeculectomy. It's mostly done under local anesthetic, but a general anesthetic can be given if needed. It's a bit more work after the operation to get the desired result. And generally, I say to my patient, there's a 3 months is a time when it might need manipulations and all that to get the desired result. But as with any surgery, there are risks and complications. It's not without risk. Important to know, but the recent development in trabeculectomy have improved the technique, and it's much less of a risk and complications. If this operation fails, we can always do another trabeculectomy, or as mentioned earlier, we can do a tube surgery. So there are options if one operation fails. Just a brief word about the minimally invasive glaucoma surgery. These are various types of tiny implants in the eye, which are injected or inserted in the eye with small cuts in the eye. Now, again, as I mentioned earlier, not every procedure is fit for everyone. These are micro-incision or minimally invasive surgery. They have a lower risk. Because they have a lower risk, they can be done much earlier in the journey. They don't need any additional technology apart from the actual device, and it does not prevent us from any other surgery if needed in future. So who are the candidate for MIGS? Now, generally, we don't advise minimally invasive for patients who got advanced disease. They are generally limited to mild or moderate disease. For open angles and not for closed angles, it causes moderate reduction in the intraocular pressure. So let's someone have got a pressure of 30, it might reduce the pressure by 10, 11 millimeters, but we may not expect that it will bring the pressure down to 9, 10, 11, which doesn't happen usually with the MIGS, more common with the trabeculectomy. Presence, if you got a cataract, then it's always help because generally the surgeon will combine the MIGS with the cataract surgery and you get better results. And there is a low risk of complications compared to more invasive procedures. But there are limitations. As I said, we cannot offer this to everyone. Not suitable for advanced glaucoma, not suitable for people who got a very bad ocular surface or have previous surgery. They may not be a good candidate for MIGS. The minimally invasive surgery, it does reduce the number of drops, but it may not take you off completely off the drops, which a trabeculectomy might do. It can be combined with the cataract surgery, and as we speak, more and more evidence in favor of MIGS are coming. So there is a lack of evidence at the moment about this surgery. And the last of all is tube surgery. So these are, again, you can see it looks quite big devices. These are generally done people who got complicated glaucoma, like inflammation, uveitis, trauma, previous surgery, and these implants can be inserted, and they again are quite successful in reducing the intraocular pressure. So you can see there are a whole range of options to treat glaucoma, and which has helped immensely in decreasing the burden of the disease and help. But again, something which is very close to my heart is information. I regularly, I will say, I see patients who are young professionals, but still may not be completely aware of what glaucoma is. Yeah, they are busy with their life, and okay, I don't have any problem. We are human being. We don't take paracetamol till we have the headache, and that's similar here. In fact, the drops which we give, that causes more irritation and all that, and that might put some people off. Why I need medication? I don't have any problem, and that's where the problem lies. So one of the things which we developed, and I can see now, is the information. And this is again a small diary which is used by the patient to log down whatever is happening, pressures. It can have information about glaucoma and all that, and which helps. So taking responsibility of your disease, knowing it better, asking questions, that is always desirable and always helps to manage your condition better. So now we come back to our original questions, that might glaucoma is getting worse, what might happen? So fortunately, as I mentioned earlier, the visual impairment or blindness is not common with glaucoma, but still this is one of the commonest cause of blindness. We are living longer. If we look at in 1920 in England, a male person the life expectancy was 55 years, and a female 59 years. So female always live longer than male for some reason or the other. But if you look at in 2019, the life expectancy of a male is 80 years and a female is 84 years. So we are living longer, which means if you are diagnosed with glaucoma at the age of 40 or 50, there are many years. I always say to my patient that I'm targeting 100 years. So if I diagnose someone glaucoma at 50 years, I say, okay, I have to look after your glaucoma if I survive for the next 50 years. And that's what my target is. So again, as we live longer, so we have to be there more people can go blind because we are living longer. Very important factor. So who go blind with glaucoma? In my experience, people who go blind with glaucoma are those who are undiagnosed, who are not going to see their optician on a regular basis, missing optician appointment for, let's say, 6, 7, 8 years. They are the ones who are diagnosed late with glaucoma, which already advanced glaucoma, and they are untreated. So these are the people, I believe, they are more at risk of visual impairment or blindness during their life. The other group who I see is treatment adherence for some or other reason. If you're not using your drops properly, for some or other reason, mainly in poor countries, then that's where people go blind, that the pressure doesn't go down. The other high risk groups are people who got multiple eye problems or secondary glaucoma because they got high pressure glaucoma, the pressures are 50, 55, and they are at higher risk of sight loss because of glaucoma. But generally speaking, most of the people will not go blind. Now, another very important thing, sometimes we often hear, okay, why I need to come every 6 months, every year, or every 9 months to check my glaucoma? Unfortunately, the progression of glaucoma is not linear. So it's not that it will slowly, gradually get worse. That's not always correct. That's a misnomer. The progression can be unpredictable, non-linear, and that's why a regular monitoring is needed. And we shouldn't trivialize or assume, okay, not many people will go blind and perhaps I'm in that group. No, I will not assume that. I will make sure that my glaucoma is taken well care of. Evidence have shown that 10% of patients on regular treatment in our clinic will have visual impairment. So again, it's quite a significant 1 in 10 will have visual impairment despite treatment, but that is over 15 to 20 years. So very important. If someone glaucoma is getting worse after being diagnosed, start the drops. If the drops are not working or allergic to drops, you can use preservative-free drops. We have an option of laser. If that is not working, then we offer surgery. Yeah, most of the time, if we offer trabeculectomy, that will work, and the patient glaucoma will be stable for a few years. If trabeculectomy gets scarred or started failing, then we try to work on the previous trabeculectomy to get it work, which is something called needling. But otherwise, we can always do another trabeculectomy, or we can put a tube in, and that will help control the pressure. Sometimes even if that doesn't work, or my glaucoma is getting worse, then we can do, as I mentioned, cyclodiode laser, which is very gentle, but can turn the tap a bit slow and help reduce the pressure, and we can always repeat that later. So that will sort of a stepwise approach we do to get the desired target intraocular pressure to prevent blindness. And that's how we'll do that. So many things which can be done to help control the pressure. But one of the things which I strongly believe, if the medicines are doing their job, but right from the word go, when someone is diagnosed with glaucoma, which I must accept that we are guilty, but we can't spend that much of time in the clinic with the patient talking about lifestyle changes. It's absolutely essential in my view. Yeah, and whenever we do any support group meetings here and all that, we talk a lot about the lifestyle changes, day-to-day things which you can. Now they will not reduce your pressure, but might help things. A number of things like exercise. There are some yogas. Again, take appropriate advice because some yoga may not be good for your health. Nutritional changes, yeah. Some kind of foods. All these things will help in a small way, and which is very vital. I have patients who got end-stage glaucoma, and during this COVID period, I talk to them every 4 weeks and just need a bit of reassurance. Doctor, what can I do? My glaucoma is getting worse. Yes, do these small things. Again, we cannot stop it, but it's a fight between the age and the glaucoma and the blindness. So my job is to prevent the blindness. That's what, and small things can help. Very, very important. But unfortunately, as I mentioned, some people will have visual impairment or will go blind. And the next thing we discuss is how we cope with the sight loss. Now, it's natural to be upset when people lose eyesight. And I think it hurts me as well as a doctor when I see one of my patient glaucoma is winning the battle over the treatment, and it's natural to be upset. But again, we need to look into how we need to cope with the rest of the thing. It's very common to be worried about the future, and one of the common worry is driving. And I'm aware that you already had the webinar on the driving, and I'm sure you know about this. But that's one of the common worry. But one of the thing I always remember, some information from the IGA, which said that a person can have a taxi 2 to 3 times a week, which is cheaper than having a car. If we add up the cost of the registration and everything, servicing and all that, so there's never say never no. So you can have probably can have a taxi. So again, we need to look into alternative options. One of the common things people say, why me? Why, what I have done? Have I done anything wrong? Don't feel guilty. Don't blame yourself. That's I tell my patient, nothing you have done wrong. I say my patient is hard luck. Yeah, you got all the risk factor, but yes, don't blame yourself. Don't feel guilty about it. You have not done anything wrong. What can I do from my side? Yes, as I mentioned, you can do many things from your side, using drops in a proper way and not missing drops, and some of the lifestyle changes and a regular monitoring. That what you can do from your side to prevent your glaucoma getting worse. One of the other thing is alternative to medicine, the traditional drops and surgery. Are there any other alternatives? There is evidence about a few things, which I'm sure people who got advanced glaucoma like ginkgo biloba and a few things. But again, please talk to your doctor if you consider anything. Don't take it yourself. Do let your doctor know, because sometimes when I do surgery and I know patients are on alternative medicine, it may not be a good idea. So but these are some of the things which you need to remember when people who got visual impairment. One of the other things during this journey of yours or any glaucoma patient is the support system, and that's where the organizations like Glaucoma UK come in to help. And it's an excellent organization. I wish every country have got similar organization to help patients with glaucoma. Perhaps you're aware of this helpline number. We in all our clinics we got this sightline help and number, very efficient. I always on a regular basis hear very positive things about the support they get from Glaucoma UK, previously called IGA. Very useful. Excellent leaflet, I will say. As you all know, in social media and internet, there are a lot of rubbish things. Don't listen to them. Just follow. I always advise my patient to go to the Glaucoma UK, and the leaflets are about real, authentic information. The buddy scheme is great. When we list patients for trabeculectomy and all, patients are very anxious because they have heard bad things from the internet. And one thing which I suggest is to talk to people who had surgery done. We have a local buddy group as well. And I have felt always very useful if you talk to someone who had the same problem, who in the same boat as you are, and that always help. And I believe there is a buddy scheme by the Glaucoma UK. Online forums always help, is a very handy thing to have, and you can share your views and ideas, and it will benefit others as well. And the last of is support group, which is very close to my heart and extremely useful for someone having. Now you don't need all this for an acute problem like a retinal detachment and all that, but you need for glaucoma because it's a chronic condition, asymptomatic. We need information. That's why it's very important to have all this support. But there are many other support available, and these are some of the other organizations like Sight Loss, which will tell you again all the information about glaucoma. Sightline, it got an online directory of people, services, and organizations. There's something called Starting Point, which signpost family to resources and professionals to child and all, and they give a very useful information. One of the, I've heard always a good thing about this blind veterans group. Even if you have done one day in the army, you are entitled to get their help, and they provide a lot of free services, equipments, magnifiers, and support people who have visual impairment in armed forces and national service veterans. You all know about guide dogs, and again, a very useful source of support and advice. Most of the clinic, I think, in UK have ECLOs, what we call as ECLOs, is eye clinic leads and officers, and very useful resources. Get in touch with them. They will discuss with you about your eye condition, discuss with you about all the welfare benefits available, help in the employment or retraining if needed. Will advise you regarding the mental health and emotional well-being, and all other things. And they will also let you know about the voluntary organization and services. Now, I'm aware I'm running a bit late. So the other thing is registration. Now, registration, what is registration? Simply means being in touch with your local social service, that you are in the register, who as a person who are severely sight impaired or partially sighted. It's very voluntary and completely confidential. We complete a form called Certificate of Visual Impairment, which is slightly different in Scotland and England, but basically the same. Your doctor will be able to suggest whether you qualify to be registered. Once you are registered, your local council will know, and then someone will be in touch with you to provide help and support. What the registration involve? Your consultant will assess, will then register you based on two things: your visual acuity or eyesight and the field of vision. So even if you have a very good eyesight, but extremely poor visual field, someone will qualify. And there is a lot of flexibility around registration. There is no hard and fast rule about registration. Lots of benefits in your registration. Is a positive step. Don't take it as a negative, and it just informs the local council. There are lots of financial and welfare benefit, like personal independence benefit, attendance allowance, universal credit, blind person tax allowance, carers allowance. I must say some of this you may not need to be registered as, or you can still get it if you qualify. There are a lot of concession and assistance, like you get a bit of help with the travel, parking, television license, assistance from utility companies, laser concession. You may be entitled to audio description, and all this, you can get a sight test at home. So these are the benefits of getting registered. So in conclusion, the most important thing is early diagnosis and timely intervention. Very, very crucial to prevent blindness. Most of the patient diagnosed with glaucoma will not go blind, but don't want to trivialize this. Many options for treatment. Knowledge and information, extremely important, which will help you or ease off this journey. Your participation in decision making, extremely important. You should be informed about in detail, and then you decide what option you want to choose. And hopefully in future, there will be new technology which can regenerate optic nerve, and that will be very, very useful. Thank you very much. Thank you.
Right, thank you so much. There's a huge amount of information in there. So thank you, Pankaj. That was absolutely fantastic. We have quite a lot of questions that have come through on the chat, which is great. So just, sorry, the Q&A. So just a reminder, if you do have questions, post it in the Q&A, and we'll do our best to answer all of them. There's a lot, so I will prioritize according to kind of how general the question is, so it's of interest to as many people as possible. So there was a flurry of questions about lifestyle changes. So could you talk a little bit more about what's kind of known about diet and supplements and things, to sort of, you know, how much is known and what the kind of questions are and things,
yes,
and what supplements are?
Yes, so regarding the diets and supplement, this is a very common and question which we get about the diets and supplement. For few things, there is evidence to suggest that will help, like coffee. Now, there is a good evidence to suggest that over drinking of coffee is bad. What I say to my patient generally is anything excessive is bad. Yeah. Whatever diet you generally know about any other condition, for a healthy diet is good for glaucoma. Yeah. I don't suggest my patient to take loads of supplement and to spend load of money on that. A healthy, good diet is that what I suggest. Anything excessive is bad. Excess coffee, bad. Excess chocolate, bad. Anything in moderation, good. That's what the basic of the diet. And when I say yes.
And it's not that, am I right in thinking that nothing really has been proven, but you can't do any harm by eating loads of fruits and vegetables and sort of doing lots of exercise?
Absolutely. So there again, nothing is very much proven in this. There is things about magnesium, phosphate, antioxidants, see, bit of supplement won't do any harm. There's no evidence to that will do any harm, but don't take excess of supplement. Just to on a similar line, I have a patient who takes drop rather than once a day, 3 or 4 times a day, thinking that the pressure will drop more. No, similar. So if you take more supplement, let's say 3 or 4 tablets, that won't help. So yes, anything excessive is bad.
But anything healthy is good.
Yeah.
Someone's asked specifically about vitamin B3 and a study in Melbourne about that. Is there anything?
Yes, again, useful because vitamin B health is a neuroprotective, it's a nerve, and that's what optic nerve is all about. So yes, very well, B complex are good for optic nerve, or no harm in taking. But again, don't take excessive. Till you take in desired dosage, it's fine.
And if it's it protects the nerves, then presumably it might help, but you can't say that because I've taken this, my glaucoma will definitely stop getting worse. It's more just
very good question. Now that's important to know. Yeah, so by taking this supplement, so all this work as a supplement, not as a supplementary, but you can take alongside your drops and all that, because the main thing which is proven is reduction on the intraocular pressure. Anything else you do will help, but it's wrong to think that that will stop your glaucoma or will cure it. If someone sell you, which is not uncommon, I've heard this, okay, you take this and you see a difference. No, that not going to happen, but it will help in the long run. For me, even a 1 millimeter pressure is important. So similarly, if we can do anything else to help prevent glaucoma getting worse, it's good, but be sensible.
And never stop, only ever do things possibly in addition to what your doctor's prescribed. Always take eye drops, always go to hospital appointment.
In addition, and always let your doctor know. Always consult with your doctor. That will be my advice. Let your doctor know that you have been advised that you are taking this.
Yeah, great, lovely. So we've had a couple of questions about appointments and delays with COVID and routine appointments being delayed. So what should people do if their appointments or treatments and things have been postponed?
Yeah. Yes, now very good. I can see one of the question is when take something to measure intraocular pressure in home. Now there is something called the home eye care tonometer, which is not a cheap equipment. It's cost around couple of thousand pound to get that equipment. Now there's nothing better than the pressure being measured in the hospital. What we don't want is, now it's very important to have an accurate measure of pressure. Now, it might be easy for some people to measure the pressure at home, but it might be difficult for others. People who are elderly, they may not find it very easy to measure the pressure. So if you measure the pressure and if it fluctuates, that might increase your anxieties and all that during the lockdown and all that, which I'm sure we don't want. So what my advice to what I have done to my patient, I've seen who are the high risk patient, I've got them in if they are happy to come to the hospital, taking into measures and all that. If you are nearly controlled or a low risk, you have to risk and benefit. There's a more risk of COVID infection going out and all that. I won't suggest do that. Stay at home, keep using your drops whenever now the opticians are opening. So what I'm suggesting, if you have your routine appointment with the optician, get your pressure checked and let your optician know to inform us if your hospital appointment is postponed, so that we know what your status is. And if I see something dramatic happening, I will get you in the hospital, will expedite your appointment. But if we think that, okay, things are stable, nothing changing much, we'll perhaps delay your appointment because of the unprecedented circumstances. But I won't get too anxious about start measuring pressure at home, because I sometimes get a bit worried that if you get a fluctuation in the pressure, that might be more damaging to you during this time rather than a bit of millimeter pressure here and there.
Yeah, great, lovely, thank you. And so someone who's their laser treatment has been cancelled, and they're not on drops or anything at the moment. So should they push to get put on drops or wait for another?
Absolutely. I will suggest you immediately write to your doctor. Yeah, just write a letter to your doctor, because don't have an appointment, but we are every day in the hospital. Yeah, we are every day, we are seeing patient, we are dealing with urgent cases. Write a letter to your doctor that your laser appointment has been postponed, and leave it to the doctor to decide whether they will like to start drops. I've done that for quite a few of my patients who are new patient. I've never seen them before, but they were referred before the COVID by the optician with a high pressure. So what I have done, I've written to their doctor to start them on the treatment based on the referral, so that at least they got something, because we never know when they will get appointment. So I think that's a very sensible thing. You shouldn't wait, but again, write to your doctor. Your doctor will know what the situation is, and then they will do the needful. But yes, absolutely no doubt that if your laser appointment is postponed, get it started in drops.
Or if people are worried for any reason, you know, the clinics that
Right.
open, right, you can get in touch.
Absolutely. Now this is not uncommon. I see some of the patients are reluctant. They never knew that they can write to the doctor. I tell my patient, every day you write to me. I suggest not to phone. The problem with the phone is when you phone, let's say the secretary and all that, it takes a lot of time for us to get the message. When you write to the doctor, it's easy to get your notes, have a look, and then they will call you back. I call my patient on a regular basis. Either they will call you back or they will respond to you. Get in touch with the doctor. Nothing stops you from getting in touch with the doctor. Don't give my name, but I have said that to you.
Yeah. Yeah, I think that's great. That's a message that we put out a lot at the moment is, you know, get in touch if you're worried about your vision, you have any concerns at all, you know, doctors are available. Lovely. So a question about normal tension glaucoma. So my IOP in both eyes is managed to around 12 to 15 with drops, but there is a continued gradual loss of visual field. Is surgery likely to help, do you think?
Yeah. Now, very important. First of all, it depends on number of factors. That what is your age? If someone, let's say 85, 86, slowly getting worse, what I need to assess, what is the lifetime risk of you going blind? But if someone is 50, 60, 70, what rate the visual field is getting worse? And then depending on that, other treatment. Before we embark on any surgery, it's important to rule out any other factors, just like I mentioned. Are you taking any medication? Are you on beta blockers or anything like that? Because some studies have shown for normal tension glaucoma, beta blocker may not be a good idea, because that causes something called optic nerve hypoperfusion. So all these things need to be looked into. But yes, there's that's the next step. If you got a normal pressure glaucoma, your visual field is getting worse, then that's what I will, again, depends on number of factors, but will generally the trabeculectomy is a very, very good option to slow down the damage, and is very well known.
And that's the same for normal tension and kind of normal tension, higher tension.
For every glaucoma, but the problem happens in normal tension glaucoma, because people think, okay, my pressure is 12. How low you can get it? Now, so the reason behind this is what happens in normal tension glaucoma is your pressure fluctuate. So when you are getting your pressure checked, is 12, but within that 6-7 months, your pressure might be fluctuating from 12, 14, 16, 18. Now, although we do this 24-hour monitoring and all that, but evidence is there that it still may not pick up the fluctuation in the pressure. Now, how the operation helps, if we do a trabeculectomy, that avoids this damage. By doing a trabeculectomy, it prevents this fluctuation in the pressure, and it stabilizes glaucoma. I have patients who are 40-year-old, 42-year-old with a pressure of 11 with advanced glaucoma. What you do trabeculectomy. No doubt about this, and that helps stabilize the glaucoma.
Okay, thank you. We've had a question about, again, normal tension glaucoma with repeated optic nerve bleeds despite the maximum treatment. So do you have any advice about preventing the bleeds?
Yeah. So optic nerve bleed, it means someone is very much vasculopath. So just like I mentioned about migraine or cold hands and feet. So someone who are vasculopath or some problem with the vasculature get this recurrent bleed despite a low pressure. Generally, the evidence says that if you getting a recurrent bleed is a sign of, is a telltale sign, which is telling the ophthalmologist, my pressure need to be reduced further. Yeah, so number, it need to be reduced further. So again, the doctor will discuss with you. One of the things which we do in a normal tension glaucoma with repeated disc is a drop called brimonidine, which is also a neuroprotective. But the other thing, if it's despite all this thing, if the pressure are still, if they are still getting the recurrent bleed, and if there is a significant visual field defect, then the surgery might be an option. But again, remember, your doctor is the best person to decide that. They must have considered this. It's easy for me because I'm not seeing you or not, but they must have considered, and they will consider. Sometimes we don't want to jump into any surgical option because, as I mentioned, they carry the risk, so we need to look into the risk and benefit and then advise. So again, but discuss with your doctor, and they must be considering this, if not considered, or must be looking into this in future.
Lovely, thank you. I turned my video off because your image went a bit funny then, so just
okay,
you're fine now, but that's why I've turned my video off. We've had a couple of questions about how likely is it that glaucoma results in the loss of sight altogether? Do you know the stats for that? Like how many?
Sorry, tell me again, Joanna. How likely?
How many people go completely blind due to glaucoma? Do you know
yes,
that?
so yeah. So the evidence again from the US and UK study is, as I mentioned, in a glaucoma, so 10% of these are patients who are diagnosed, who are treated. 10% of them will have some sort of visual impairment. Yeah, 5%, less than 5% will go blind. This is a rough estimate as per the evidence. When we say blind, it's both eyes involved. When we say visual impairment, it's generally one eye. So this is a rough figure of number of people who will, despite all the available treatment and all that.
And am I right in thinking that that's the earlier you're diagnosed, then that 5% chance even gets a bit lower?
Absolutely. As I mentioned in my talk, who are the people who go blind? They are late presenters. The early you diagnosed, the early you treated, you won't go blind. That's what I tell my patient. That there was a good leaflet from IGA, if I remember, which I quote to my patient every time. When you are diagnosed with glaucoma is the good news, and immediately the patient think, okay, why the doctor is saying me the good news? I got this diagnosis. Because it's a good news, because 50% people in the community, 50% of the glaucoma are undiagnosed. So that's the problem. Once you are diagnosed, you are treated, you will not go blind. Early, I mean, yeah. If you are diagnosed early, you are treated, you won't go blind. So diagnosis, early detection is the single most important thing.
Lovely, thank you so much. That's very reassuring. I'm going to switch on another poll now, which is just to sort of see where we've got to. So we've got about 3 minutes left. So I'm just going to launch that second poll. We've got time for a few more questions. Can you have more than one type of surgery?
Yes, you can have. Yeah, you can have more than one type of surgery. So you can have a mix. If that doesn't work, you can have a trabeculectomy. If that doesn't work, you can have a tube surgery. If that doesn't work, you can have a laser. So yes, you can have more than one kind of a surgery. I can see another question there, that I have had glaucoma for 30 years. 15 years ago, I had my right eye removed due to detached retina. I've been told that I have a cataract which need to be removed. I'm very nervous to have this done. What are the risks? Yeah. Now, if you heard my talk, cataract surgery helps your glaucoma. By delaying the surgery, what's the problem? You are having a reduced quality of life because of the vision. You still have glaucoma, that won't get any better. That will remain the same. I completely understand your worry. You're worried about the risk of retinal detachment, which is always there. If you have a retinal detachment in one eye, if not because of the trauma or anything like that, you can get in the other eye as well. But one of the important thing to understand here is, by delaying it, no benefit. The risk doesn't get any better by delaying it. So that's if that helps you in any way. I can see another question. Are visual field tests being done at your hospital? Yes, on a regular basis, they are done at our hospital. Initially we didn't do it for a few weeks, I will say, but now it's very much done on a regular basis. Yeah, Joanne.
So there's been a question about the role of the Amsler grid in monitoring. So do you want to explain what that is?
Now, so Amsler grid is a test which you see squares and all that, and is usually done for macular degeneration, not for glaucoma. So there is no role of Amsler grid in glaucoma. Amstelgrade is generally done for macular degeneration. As macular degeneration can be a dry type and the wet type. So Amstelgrade will let you know whether the macular degeneration have gone worse or not, but not for glaucoma.
Yeah, lovely, thank you. Another question from Facebook was, how important are sort of sunglasses? I guess for glare, it's more helpful, but could you talk that through?
Very good question. So sunglasses will help you from developing cataract, as such UV protection and all that. If you got glaucoma, and people who, and good that you asked me this question, people who got advanced glaucoma, I will suggest to wear amber color glasses. That improves the quality of life. If you wear amber color glasses, that will cause less of you will be able to cope with the sunlight on and all. So that is a preferred glasses for people with glaucoma, amber color glasses. And sunlight usually, the sunglasses are good for preventing cataract and all that if you got very bright sunny days and all. Yeah.
And that's not to manage the kind of impact of the glaucoma. It won't affect the development of the glaucoma.
No,
it's just to make life easier.
It won't. Yeah.
Lovely. Right. We'll a couple more questions. I know we're basically on 8 o'clock. I'm long-sighted in one eye and short-sighted in the other. How can that affect my glaucoma?
Okay. So it depends whether, first of all, if let's say you're wrong-sighted in one eye and short-sighted in another eye, but no problem with glaucoma, doesn't matter. You see your optician on a 2-yearly basis and all, and they will keep an eye. So just having long-sighted or short-sighted, someone will get glaucoma. That's not the case. You need to have other risk factors and all that, and you need to have a hard luck to develop glaucoma. But for general purpose, it doesn't affect. Yeah, if you are, as I mentioned in my talk, if you are short-sighted, you are at more risk of open angle glaucoma. If you are long-sighted, you are at risk of angle closure glaucoma. But it doesn't mean that anyone will have, with short-sighted or long-sighted, will have glaucoma. Regularly check, and that will, yeah.
Yeah, lovely. And then the last question, when I was about to have my operation, why was I told that I could lose another 5% of sight before the day of the operation? Is that someone who's got?
So it depends on what type of operation they were talking about. If let's say that was a trabeculectomy operation, one of the long-term effect of trabeculectomy, you can develop a bit of cataract, and that's what you have been told, that you will reduce 5% of your vision, but that probably is temporary, because once you get the cataract surgery done, it will be fine. So less of the cataract is less of a worry. The main thing is to control the glaucoma. The another reason why someone is told that you can have some loss of sight is someone with a very advanced glaucoma can something called wipeout, but is not common at all. So you are much safer to have the operation than not to have the operation. But again, your doctor will be the best person to advise you depending upon your results and all.
Right, that's it. So thank you so much. We've gone ever so slightly over, but we've done all the questions. So thank you so much for giving up your time, Pankaj. That was really
thanks, Jo. Thank you very much.
Thank you so much. When we close this session, there will be a survey that pops up on your screens, or you'll get an email about it tomorrow. We would be very grateful if you could fill that in, so we can plan future sessions and sort of make sure that these groups work for you. So we're very grateful if you can do that. Thank you so much for your time, everyone, and thank you so much, Pankaj, and have a great evening, everyone.
Thank you for the opportunity. Thank you. Bye-bye.
Bye.